Good afternoon, everybody, and welcome to our 23rd iGeriCare live event. Today is January 28th, 2021, and this is a very timely and hot topic today. So over the past year, of course, we've all been anxiously awaiting news of how we can tackle the COVID-19 pandemic. And with the news and the recent arrival of a COVID-19 vaccine, now that vaccines have become available, we thought this was a great opportunity to talk about that topic in a live event. And we're really fortunate to have Dr. Zain Chagla here with us today. Dr. Chagla is a specialist in internal medicine, tropical medicine, and infectious diseases. He's also a consultant physician at St. Joseph's Hospital and Hamilton Health Sciences, and an assistant professor of medicine at McMaster University, adjunct faculty at the University of Namibia in the Department of Medicine there. And Dr. Chagla has been incredibly busy and incredibly generous with his time in helping to explain various elements of the coronavirus and the COVID-19 pandemic. And we're really glad to have you here today to help better understand and unpack some of the issues related to the COVID-19 vaccine. So thank you for joining us, Dr. Chagla.
Thanks for having me.
So a couple of general notes. You can submit questions through the commenting feed. If you're watching on Facebook, you can also submit questions through the chat bot on our events page. We'll try to stay on time and get through as many of the questions as we can. I want everybody to maintain a civil tone, because for some reason, this has become a bit of a hot button topic, and people don't always maintain civility. It's important for all of us to remember, though, that no matter what's happening with the vaccine, physical distancing will remain important. So continue to practice that. Mask wearing remains important. And that might be one of the things that we talk a little bit about, is why are those things still so important? But washing hands, limiting physical interactions, all those things that people have been doing, they continue to be really important, even in the event of vaccination, which we can talk about. So without further ado, how about we just start off with a few basics about the coronavirus vaccine? Dr. Chagla, what can you tell us, like maybe some basics about the vaccine?
Yeah, so this is a really exciting time that we have a vaccine available, and I think people, could just reflect on the fact that we were talking about this disease starting to come to Canada about a year ago, and we were talking about a vaccine campaign for this disease now a year later. So these are mRNA vaccines, and so vaccines are baseline drugs that we use, and many of you have gotten them in your lifetime, or kids get them as part of their growing up. And they're essentially ways to trick your immune system into, lived experience with an infection without necessarily having the infection itself. And so we have tons of vaccines for hepatitis, for influenza. And again, the whole point of these vaccines that are all a little bit different is to tell your immune system and train your immune system on what to do, such that it prevents you from getting infected when you're exposed. Or even if you do develop the disease, because you have an immune response, it helps prevent you from getting severely sick or dying. So we have two vaccines on the market, the Pfizer-BioNTech vaccine and the Moderna vaccine. These are mRNA vaccines. And so this is a very new mechanism of vaccine, but it actually uses a pathway in humans that's well established for other vaccines. And so mRNA is the messenger of all life forms, and the analogy I like to use is if you find a recipe online that you want to make, mRNA is essentially just printing it off and then having it in front of you while you're making whatever you're going to make for a dish. So that mRNA gives you the instructions on what to do, and essentially it tricks your cells into making some of the proteins that are expressed on the coronavirus. Those proteins then go to the top of the cell and even out of the cell, and trigger our body as if coronavirus was there. The good news is this: there's no live components to this, so there is no live vaccine that's introduced here. So our body has a chance to train with some of the proteins without necessarily actually having to deal with fighting the infection itself. And the end result is we make antibodies, and our T cells, which are our helper cells, get triggered by this infection, have a learned memory of how to deal with this infection, such that the time we have to deal with it for real, we already have some experience in how to deal with it. And that hopefully prevents people from getting infected if they're exposed, or if they do get infected, that they minimize their symptoms as the body knows what to do here.
Is there anything? Is there anything like completely different about mRNA vaccines? Because in some ways, it sounds like the vaccines that we've all known and come to love, like that have prevented polio and measles and things like that, maybe just with a slightly different starting protein or something.
Yeah, exactly. So, most of us have gotten the flu shot this year. The flu shot is a bunch of proteins that are on the top of the flu virus that we inject in, trick our bodies into seeing them such that they respond well. The difference here is, going back to that cooking analogy, is rather than having the full meal kind of injected into you, like the end product, we are using the photocopy or the printout of the recipe online, putting that into our body instead, and then getting the cooked product internally. And the benefits are, that we make a better immune response to it, because our bodies are actually quite used to dealing with pathogens after they've been digested by our body, not necessarily when they've been injected into our body. And so it kind of trains that response quite well. It makes it more stable kind of for getting a good immune response. And the nice thing about this is it is very, very easy to develop in that sense. So, people have talked a lot about how this vaccine may have seemed really quick, but this technology was actually there 2, 3, 5 years ago. It's really the first time it's had to be harnessed to use this, so that you started with the full dish or the protein in mind, and then you just worked back to the photocopy of the recipe. And then use that to move on. So that's the only real difference. But the end effect is exactly the same. You have a protein that gets expressed by the body that triggers an immune response, much like the influenza vaccine. It's just the upstream stuff is a little bit different.
And I guess what you just explained helps to partly explain perhaps why it's so effective. Because when I think about the influenza vaccine, it's kind of like, if you have a good year, maybe it's 80% effective at best. But these vaccines are really very effective, like 94, 95% is and actually, if I remember correctly, the 5% where people might have gotten COVID-19, the disease was less serious. The illness was less serious.
Absolutely.
Is that?
Yeah, absolutely. So we saw two things in these trials. One, after the second dose was given and we followed people out for months or for weeks, there was a significant difference. And again, 94 to 95% difference between Pfizer, BioNTech, and Moderna for people who had gotten just a placebo shot versus those who had gotten the Moderna vaccine. And this is for people that had symptomatic COVID-19. So we following those people kind of as well in terms of how sick they got. Again, the severe cases were much higher in the group that got the placebo versus the group that got the vaccine. And so certainly it definitely showed these help prevent people from getting symptomatic COVID-19. But even in those that get ill, there is still some protection from getting serious symptoms or hospitalized with COVID-19, which is that double benefit here.
And pretty much any medicine or even vaccines have some kind of potential side effects. What would you say are the most common side effects with the vaccines so far?
So for any vaccine, and people call it a side effect, but it's actually what your body should be doing. Is that you get a sore arm, you may get a fever, you may get some muscle pains, and feeling tired and achy. And people call it a side effect, but in some sense, because this immunization is really there to trigger your immune system to start working and figuring out what happens when you see COVID for real. This is actually just what our immune system should be doing, is when we encounter a pathogen, we get fevers, headaches, muscle pains, joint pains. And so, it's similar here, that all this vaccine is doing is triggering that immune response. It may be uncomfortable though, but certainly these are the typical things, particularly the pain at the injection site, which about 80% of people do get, which is, again, your cells trying to figure out what's going on there. And then feeling tired, a bit run down, muscle pains. After the second shot, there's a little bit more of these symptoms as well, just because your body's already primed to know what's going on, and so it gets even more of a robust response. But generally, these settle down in 48 hours. People feel well after that. So they are benign in that sense. If you look at other vaccinations, like the Shingles vaccine, which is recently approved a few years ago for those over 65, the side effect profile is actually a little bit less than that in terms of having these symptoms. So shingles vaccine is a bit more immune active, and so people tended to get more muscle pains and fevers afterwards. A small number of people did get more severe reactions like redness at the site, and then a very small number of people did have allergic reactions in real life. The numbers are very, very small. So about 6.2 per million in the Pfizer arm and about 2.6 per million in the Moderna arm, in the experience that's been given in the United States, with over, I think it's about 6 or 8 million doses administered in the United States to date. Even in those that got the vaccines, all of them received treatment for their serious allergies immediately. Only a handful were actually hospitalized, and none were seriously ill. All were discharged in good health afterwards. So there is a small risk of allergies associated with these vaccines. It is particularly to a couple of components, like the PEG component, which stabilizes it. But for the most part, these allergies are exceedingly rare in the hundreds and hundreds of thousands of people that have gotten these vaccines.
Are there any precautions? You mentioned if people have a known allergy, are there any other things like, again, a lot of the people who participate in our program are older adults with dementia or caregivers. Any other sort of precautions around vaccination?
So there's no precautions to the extremes of age, which is good. There were about 3,000 or so in each trial that were over the age of 65, and about 700 that were over the age of 75. Which and when you look at the analysis, the efficacy or the vaccine's effects actually work quite well in those over the age of 65 and 75. There is a little bit of a statement for women that are pregnant and breastfeeding, because these vaccines were not, pregnant women and breastfeeding women were not included in these clinical trials. A few women did become pregnant while undergoing the trial, but not enough to make any solid conclusions from. There is a risk and value judgment in that sense. There's nothing in these vaccines that would suggest any type of fetal development issue, breastfeeding issue, and that type of thing. It's just, they just have not been studied in this group. And so knowing that pregnant women are at slightly higher risk of COVID complications, especially ones that are on the front lines or working in long-term care, it certainly should be offered to women in that context with a good risk and benefit discussion. It's not an absolute do not give, but just, that informed consent that we just don't know what it looks like in pregnant women, although we don't expect there being issues in pregnant women. And there certainly are many other vaccines we give during pregnancy actually to protect mother and the fetus, like the influenza vaccine, amongst others. The only other thing is in children, so under the age of 16 in the Pfizer arm, or the under the age of 18 in Moderna, these again were not trialed. There are big clinical trials ongoing now, but until that data starts coming out, we can't recommend them in children. Although again, the data seems like it should be safe in children. It's just that recommendation has to be made based on the clinical trials. For those who are immunosuppressed or who have autoimmune diseases, there isn't a particular concern, knowing that people who have medications that suppress their immune system or autoimmune diseases may not respond as well to the vaccine. there just needs to be a discussion here around that. As well, we don't know in terms of just the immune side effects, particularly people who are on chemotherapy, if they get mixed up and considered as part of the chemotherapy effects versus the immune side effects. It gets to be a little bit tricky in this population. But generally, we are still recommending this vaccine in that population. It's just that they have to understand that it may not be as effective as these 95% numbers, as their immune system is a bit compromised. But again, these populations also have a significant risk of dying or having significant complications if they get COVID-19. And so again, that's part of that risk and benefit discussion.
So that's great. Why don't we go to a few questions, and these are questions coming in from our listeners. Sometimes we don't have the answer, and we'll just admit it, but we may be able to help out with a few. So here's an item: is dementia considered an underlying medical condition that puts a person at more risk for a bad outcome if he or she tests positive for COVID-19? You may, I can tell you what I understand, and my colleague Dr. Stramko has also contributed here too, that most likely dementia doesn't necessarily increase the risk for COVID-19, which is the respiratory illness caused by the new coronavirus. Just like dementia doesn't necessarily increase the risk for the flu. However, some of the other conditions, the other risk factors that may go along with dementia or frailty, which you mentioned, some of those other things, increased age, the risk that people who are older who may also be at risk of dementia may also have respiratory illness, things that do put them. So I guess we are seeing a higher or a high percentage of people with dementia with coronavirus infections. I think the other thing that I've seen in the hospital situation with the medical psychiatry service is the risk of people with dementia developing maybe atypical symptoms. So they may develop a delirium or confusion rather than just the breathing types of symptoms. And I've also seen some patients developing hallucinations or delusions during the infection without necessarily having very prominent breathing symptoms. So I'm not sure if you have anything else that.
Yeah, no, I agree with you, and I think if you put it on paper, the highest risk of dying and complications of COVID-19, if you could list it out, is age. And so knowing that particularly patients with dementia are over 70 and often over 80, is a risk factor, not their dementia, but their age particularly. We know obviously things like vascular dementia, cardiac risk factors and vascular risk factors are a risk for COVID-19 outcomes. And so that may be, again, an association. The places where unfortunately dementia patients live, particularly congregate care facilities, are at a higher risk of being exposed to COVID-19. It doesn't necessarily mean their outcomes are different, but there is a higher exposure risk. And as you said, the recognition of people with COVID often can be very difficult with dementia, given that they may not have the typical fevers, they may not have the typical respiratory symptoms, it may be behavioral symptoms, GI symptoms, or that type of thing.
Here's another question from Moose Jaw. Do you know when 80-year-olds in Saskatchewan might be receiving the vaccine? And I don't know I know in many provinces there have been some delays. Most provinces have identified older adults as one of the priority groups, but I know many of the provinces, like Ontario, have had to revise some of their schedules. Any comments on?
Yeah, there is a federal framework for distribution of the early vaccine. And so as many of the provinces are doing, it is really related to those living in congregate care facilities, their caregivers and people that work in those facilities, healthcare workers, and those receiving adult home care, or those in Indigenous health communities, particularly elderly communities in the Indigenous population, where there is a significant burden of illness and death. The next priority group is those that are vulnerable based on medical risk factors. And so that would include people of a particular age, and many provinces are just stratifying 80 and then going down the list 75 and then starting to go down there. So I would say, most provinces are aiming for their first rollout plan. I know we're having issues with vaccine supply, but, by March or April for that first group to be done. And the next and most important group, as we talk about, if we can put anything on paper, age is going to be the highest risk factor. That is probably the next group after these highest risk and healthcare folks are prioritized.
Yeah, thank you. A question from Ontario about when is Johnson & Johnson's vaccine going to be available?
Yeah, absolutely. So I will mention there are two other vaccines, one that is approved in the UK, the AstraZeneca and Oxford vaccine, and the other is the Johnson & Johnson vaccine, which is mentioned here. These are adenovirus-based vaccines. So again, a newer technology, although it's been used more extensively in humans. There was an Ebola vaccine that was built on this model. And essentially this, rather than using the mRNA, like the cookbook, basically, the copy of the cookbook online, this uses an adenovirus, which is a benign virus to humans that doesn't replicate in humans, and uses that to get the genetic materials into the host, and then use that to do the exact same thing, make the proteins that it should. And so those vaccines have an advantage of being really heat stable. So, really kind of normal temperatures. And the Johnson & Johnson vaccine particularly may have some evidence for a single dose, which is obviously, as things are going on today, is something really important. The AstraZeneca data is out there, and there are a little bit of issues. There's a bit of, even today, some controversy of whether or not there is even a significant effect in those over 65. It just hasn't been studied enough. And the Johnson & Johnson data is supposed to be released next week. So we'll have a better sense. If it does look like that data is promising, I can expect many countries are going to be very much working to get this approved ASAP, knowing the vaccine supply chain and the potential benefits of having a single dose, which will make a rollout much, much easier.
When I think even storing like some of the vaccines, I can't remember which one has to be cold stored at a very low temperature, which not all, many of us would get vaccines through our family physician's office. They don't necessarily have a minus 80 Celsius fridge that can handle and store the product. So there's a lot of the last mile and the nitty gritty details make a difference. So I think having more vaccines, and I guess we're focused on the Canadian context, but in terms of sort of global equity and delivery of vaccines worldwide, a single dose and an easier to distribute vaccine would make a big difference. So.
Absolutely.
This is a question from Ottawa. I was present during a number of discussions where the various phases of the clinical trials pertaining to the vaccines were brought up and concerns raised. It was expressed that those have not been followed in terms of the sequence, and not all phases were completed. Considering the urgency of the need for the vaccines, were those followed? And is that an issue that perhaps should be explained and addressed? And I do actually have a couple of slides that might be helpful to pull up, and maybe you can just speak to that while we're looking at it.
So there were definitely three phases to this vaccine. You can look them up. They're available online, the phase 1, 2, and 3 data. And just to explain what phases are. So phase 1 is, is this vaccine safe, and what is the right dose of this vaccine? So you give it to healthy people. They're not necessarily seeing if it prevents COVID. It's just seeing if it's well tolerated. They'll look at their antibody levels to see if it generates a response, and they'll look for side effects to make sure that it's safe to start rolling further. The phase 2 trial is a lot more volunteers. And again, gets more data around, things like antibody levels. Again, is it sustained effect outside of those 10 people? Is it safer on a larger number of people? And what's the safest and most effective dose? They can do a lot more study in that phase 2 data. So phase 1 data for this came out, I think, in about April, phase 2 in about July. and then phase 3, which came out just on New Year's Eve, actually, but some of the press releases that happened right before then. So these were all followed appropriately. And just to, in context, the phase 3 trial for this vaccine had about 20, for Pfizer, had about 20,000 individuals in each arm, so about 45,000 total. The Moderna trial had about 30,000 or so about 15,000 in each arm. If you give you context, the shingles vaccine had about 15, 20,000 individuals total. So the data set is actually much bigger for this vaccine. The other issue is, compared to other vaccines, I'll go back to the shingles example. It takes a long time for one to develop shingles. So you give them the vaccine and you have to watch them over time to see if they get shingles. And that can sometimes take 5-10 years. It may not even happen in someone's lifetime. The other issue, and it's unfortunate with the situation we live in, is that people are developing COVID left and right. And so, to actually get a data set where you give everyone the vaccine and you wait for them to get COVID, well, unfortunately, our world is and especially, the USA, Brazil, where many of these vaccines were studied, there's a lot of COVID there, and people were getting COVID after the vaccine. And so, that is another reason why the phase 3 trial took much less time than other vaccines trials, because they actually got the number of people they needed, which is, again, unfortunate based on the world today. Then the phase 3 trial goes to Health Canada, who approves of it. Sorry, go ahead, Anthony. I think you were about to say something.
I was just going to say that, as you said, there's been a lot of research on mRNA. Actually, I listened to a really entertaining podcast on This American Life, and it was talking about the scientists who had been sort of working away at this 5, 6, 7 years ago, who couldn't even get their work published until all of a sudden, now everybody's interested in the messenger RNA of the outside of the coronavirus. But so a lot of work had gone into this. As they say, sometimes it takes several years to become an overnight success. And then the phases were actually handled in a similar way to, if arguably maybe a bit more rigorous than some of our other products. And I guess Health Canada probably reviewed this around the same time, or maybe even after it was reviewed by some of the other, like the FDA in the United States.
So there is that one difference here, is that it was, typically, again, going back to the shingles vaccine, you still have people, again, a phase 3 trial, you have independent people that do this study, independent people that monitor the safety, and independent people that monitor the ethics of the trial. And so those are all still within this phase 3 trial. Typically, what would happen is you do the phase 3 trial, you get the results, you submit that to Health Canada. Health Canada starts from scratch and then moves on to eventually approve the drug. And that's what happened with the shingles vaccine. The study came out in 2012. It was submitted to Health Canada. They did their review. And by, I think 2014, we started seeing the shingles vaccine starting to come to the market. The issue, obviously knowing we are in a global pandemic, and then, we would not want to wait on a vaccine that's effective while, thousands of people die while we were going through a review process. There was an embargo, a confidential agreement between the companies and Health Canada, the FDA, and other organizations to essentially start feeding the phase 3 data real time to those agencies, such that once that phase 3 data was complete, you didn't have that much of a lag between Health Canada starting their process to finally evaluate the drug. There was still some of that need, and so we saw the phase 3 data come out, I want to say like late November, early December. And then it was mid-December when we saw Health Canada's final approval of the vaccine, basically. And again, that was just making sure that everything was aligned, everything was going well, and any inconsistencies were matched. And similar to the FDA, the European Union, the UK, that approved it really based on that. So that is the one difference here, is that time was saved between that Health Canada step. They still reviewed the data with the same rigor as other vaccines, but given the timeline, they were reviewing it along the time the phase 3 trials were being done, rather than after the phase 3 trial was done.
All right. Few other questions or comments. My mother's in long-term care. I'm an essential caregiver. I've never experienced so much relief as I did the day the paramedics came into the home and vaccinated all the residents. We now have both had our first shots. I got mine at the hospital, and hopefully we'll be getting my second tomorrow. We don't have a second vaccine date for Mom and the other residents, but presumably they will get theirs on schedule. We are so lucky to be living in Canada.
Yeah, and great to hear. And again, the Ontario guideline, I know there is vaccine shortage in Ontario. The recommendation, the reason why healthcare workers are getting vaccines probably closer to day 35 to 42 is that whatever limited supply we have is being funneled to make sure that long-term care residents get their dose 1 and dose 2 within about 28 days. So for Pfizer, and Moderna will be on time for both dose 1 and dose 2. So, hopefully at least the folks in care facilities will get their full series right on time. And again, limited doses will make sure with an objective that everyone gets their 2 doses. And I think the objective is to get the first dose into everyone across the province by the end of next week, I think, February 5th.
So that's in Ontario, and I think different provinces. I want to follow up on that because there was a comment from one of the other viewers that says, we've always been led by the science and the research to be confident about it. The both manufacturers mentioned that their products work well with 2 inoculations. Those are the 2 available currently. In one case, 28 days apart. Now we have medical officials moving forward with an inoculation strategy that sets aside the manufacturer's suggested use in order to give more people at least 1 dose. However, it's obvious that a proper risk analysis hasn't necessarily been taken into account, focusing on what's happening now with the problem with the supply chain. What led the health authorities into taking this gamble? What science and or research proved this to be a worthwhile approach? Sort of either the 1 dose is better than none, or it's okay to delay that second dose until like 35 to 42 days after, rather than the earlier one.
Yeah. So, I mean, the 1 dose strategy, and if you go through the clinical trials, you still see when people get their first dose, particularly kind of 14 days after their first dose, you see a difference showing up between individuals who got the vaccine versus the placebo. It's not as profound as people who get their first and second dose, but there is a definite difference. And about the time the first dose is through, by time people are ready for their second dose, it's about 80 to 90% effective at that point, depending on what time point you look at. So, there's been a lot of push, and the UK is really banking on this strategy to say, listen, if we just have doses, let's get people to 80% and get more out there, and we can figure it out as more comes in that sense. And they are doing a good job actually studying this. So we'll have more data in the weeks to come to say, what does the profile of someone look like who's only got 1 dose? The problem is we don't know, and we don't know how long that immunity lasts and whether or not, it impairs the second dose, or it decays after 3 to 6 months to the point where someone needs to do the series again. And so Canada, the World Health Organization, the CDC has all recommended that people get at least the Pfizer-BioNTech by day 42. That 42 days is actually important. So it's not an arbitrary number. When you look at Pfizer's trial, the majority of people did get their dose by day 21, but there were some people that got it as less than, as low as day 19 and as high as day 42. And actually, they were actually included in part of the analysis of that 95% effectiveness. And that's where this strategy of, yes, try to get it in on time, but if you have to, push it to day 42, knowing that young people have relatively good immune systems. And so this has mainly been pushed out to healthcare workers more than anything else. And then long-term care residents get the doses closer to on time. Realistically with the supply demand too. And again, this will be studied. This is still within the scope of what was given in the clinical trials, but we will get more data of what an individual looks like when they get 2 doses that are a bit staggered more than anything else. Again, from the Pfizer data, it seemed like there was no major difference, but there weren't a ton of numbers. And so we'll see what this shows down the line in that sense.
Okay, thank you. That's helpful. Here's another question, and not the submitter says not sure if Dr. Chagla will have an answer, but here goes. We've heard in the media that there's anywhere from 50 to 80% acceptance level of the vaccine by healthcare workers. Do you know what the actual number is? Is there a risk to vaccinated residents in long-term care homes if some workers are not vaccinated? Is it standard practice or possible to make vaccinations a condition of employment in long-term care homes?
Yeah, and it's a really good question. There is some vaccine hesitation out there. And it's the reason why we have these events and we discuss and put things out transparently and ask questions. And even in healthcare workers, there's some of that hesitation. There's been local championing and making sure that people understand that are making an informed decision. There's no pressure right now. No, unfortunately, I think we have to wait to see what exactly these vaccines look like in real life. A clinical trial is one thing, but putting it out in real life, also ensuring that safety and real life data, which is being monitored day by day by day, before we start making any type of sweeping laws or mandates to say person X or Y needs to be vaccinated. Knowing how these vaccines work, though, yes, there is a risk, for individuals who aren't vaccinated to bring COVID into care facilities and that type of thing. But the best thing one can do if you are in those facilities is personally vaccinate, as your risk of acquiring COVID-19 goes down. But even if that does happen, your risk of severe disease goes down with it in that sense. That is probably the biggest intervention we have for COVID-19 to this point. And so, I agree, there's going to be a lot that will need to be figured out in terms of employment and mandates and, who can work in particular areas, who's not vaccinated. Right now, with supply low, while safety is still being monitored, I think we have to just expect people consider it when they're offered. If you have a loved one, really consider it if you're offered. But outside of that, I think we have to just wait until we get better data around this.
And again, it does highlight the importance of using some of the non-vaccination, non-medicine approaches, physical distancing, hand washing, mask wearing, though that the contact is so close between a healthcare worker working in long-term care that you can't realistically keep a physical distance when you're providing personal care to someone. So,
absolutely.
How do we register for the vaccine? I think this is going to differ by jurisdiction, both within the province and between provinces. So I would say probably the best advice here would be to contact your local public health office. If you have access to the website, check their website. They may have information with respect to their vaccination policies, procedure. If you work in healthcare, best to check with your employer because they may have their own vaccination strategy if you are a healthcare worker or working in long-term care. But probably the best bet for clarity on that is your local public health. And it's absolutely an evolving situation based on supply as well. And I guess maybe will change if another vaccine enters the market as well, if there's more supply.
Absolutely.
So if an older adult with dementia gets a shot, for example, the Pfizer vaccine, but does not have any kind of a reaction, does it mean that their immune system hasn't kicked in?
No, absolutely not. So in the trial, about 86% of people had a sore arm. I think about 10% of people had a fever after the vaccine. But when you look at antibody levels amongst those over the spectrum of symptoms, they really are high regardless of whether or not they had side effects or not. It's just some people, the way their bodies are programmed, how vigorous their immune response is. There are genetic factors at play here too, can make that type of reaction much more aggressively than others who may make it silently, but still have the same immune response. And similar to this COVID, some people are critically ill and some people are barely symptomatic. But when you look at them at the end of the day, they all make relatively good antibody responses. And again, it really has to deal with more than just the vaccine or the virus. It's their immune system, how it's primed and how it deals with this type of thing.
Actually, we had another virtually identical question as well. So I think that that's a really important concept. This is one. My mother's 97. She got her first dose of Pfizer, hasn't exhibited any reaction. And does this mean it hasn't stimulated her immune system, and that it won't work for this age cohort? And I think you've answered that definitively. So in some ways, maybe those people are lucky not to have exactly. Major local reactions, and I guess be reassured that the data suggests that antibodies are forming and they should have the same protection. And those patients were included in the clinical trials. So here's a question from Toronto. I'm not sure if I fully understand. If these vaccines are so safe and do not need long-term testing, why does the medical community traditionally do long-term testing?
So we're doing what's called a phase 4 trial right now. So, phase 1, phase 2, phase 3 are in, research settings, randomized trials, what we talked about. Phase 4 is long-term safety data, right? And so that's when we administer it. We have this last step in this diagram, the continuous monitoring to inform safety. And realistically, we have trials of 10, 20,000 individuals, which is a lot. When you administer it to 1 million individuals, you may not pick up on a reaction that, was in the original 10,000. There's always a risk of this. And again, this is with any medication, any vaccine, anything really comes to the market. You have very limited experience in the trials. As you put it into reality, you always want to make sure that you monitor for what's going on when the population starts taking it. And that's why we do phase 4 studies. That's why we have adverse event monitoring systems, that we have international data that's collaborated to make sure that as these are rolling out, there's something that's not missed that was very rare in the study, but is slightly more common when you do it in 1 million people. And so, that's where this comes from. And again, that's a function of anything that comes to the market, not just these vaccines.
Here's another question, which is interesting in that you mentioned the shingles vaccine earlier. I'm interested in the shingles vaccine. My primary care provider says that it'll cost $200. As a Canadian pensioner, that's not an option. Do you have any suggestions for handling the high costs of some of the vaccines that are available? And I guess it doesn't sound like the COVID-19 vaccines are being charged for.
No, COVID-19 vaccines are without cost. The shingles vaccine, depending on where you live in Canada, is covered for particular age groups. You're right. There is a cost to this vaccine. It is not great. Like I agree, it's not the ideal cost. It is a multi-dose series as well. It depends on your health units. Obviously, this was something that public health units were taking a look at in terms of preventing. It is a really, really effective vaccine. The prior shingles vaccine, the old one, the live vaccine, prevented about 60% of shingles and about 60% of the nerve issue that happens with shingles. This vaccine is up to 95% effective in that sense. So it is a very, very potent vaccine. But unfortunately, it's still under patent, and there's government and cost issues and that type of thing that's led to the rollout not being funded by most governments. Hopefully, in a couple of years, we're going to see this. But I would say it's one where, if you were going to invest in a vaccine later in life, and knowing shingles can be particularly devastating for some of those with lowered immune systems, it's one to consider as part of it.
Yeah, it's really challenging when financial decisions kind of force you into a challenging decision around it. Obviously, we're fortunate in Canada in general in terms of our universal healthcare system, but we see some of the gaps in universality around some of these aspects of the healthcare system. I just can't thank you enough. I'm just going to put up a last slide as a reminder of some of the other things that we can all do to help prevent the spread of COVID-19. Now with vaccination being a new addition to the diagram to accompany mask wearing and hand washing and physical distancing. And if you do become infected, quarantining at home, you can download the COVID Alert app. I don't think we have technological herd immunity yet, from what I understand, in terms of the number of people using the app. But I think we should continue to do it because while there's hope with the vaccination, we're certainly not out of the pandemic yet. Dr. Chagla, I can't thank you enough for joining us today. I think it was a really informative discussion of the COVID-19 vaccine. Our next live event is scheduled for Wednesday, March 17th, and we have a special guest, Dr. Roger Wong, and we'll be talking a little bit more about the Canadian long-term care strategy with respect to COVID, as well as some of his work in national and international advocacy work. As always, there is a survey pinned at the top of the comments section. Please do give us some feedback. Let us know what topics you'd like in the future. We would also like to thank iGeriCare contributors generally, Canadian Centre for Aging and Brain Health Innovation, powered by Baycrest, the Jaris Centre at Hamilton Health Sciences, McMaster University, the Hamilton Health Sciences Foundation, the Alzheimer's Society Foundation, Hamilton Halton, and our team at the Division of E-Learning Innovation. And now Dr. Chagla is an honorary member. As always, if you have the opportunity, please, on the top right corner of our iGeriCare website, there's a donate button. We're really grateful for the contributions people have made to allow us to continue to bring the live events and updates to our e-learning. And as always, teamwork makes the dream work. Thanks, everybody.